10% of what you should are your employee assistance programs. I'm sure all of you have those. Now, on the one slide, the main driver for most of our poor choices, which result down the road in adverse health issues, are all of the emotional turmoil, the job dissatisfaction, the anxiety, the stresses, et cetera, the legal problems, the financial problems. That's what you're already paying your EAP, or your employee assistance provider, probably on a PM basis, already to provide. But yet, some of the utilization rates I've seen in some companies are laughably low that you're still paying for it. It's a tremendously valuable resource, and in many cases, far more valuable than telling more people to go to their primary care physician. Getting at the root cause of why people are missing more work, why they're costing you more money, why they're less productive when they do show up at work. If you look at other simple things that you can add in, and again, depends heavily on what your organization looks like. Great research, and I don't know if some of your local health carriers, Anthem or Humana, do this. Great research showing that if you only add to your health insurance plan for people who qualify because they have a host of pre-existing conditions or whatever, 6 free visits with a certified nutritionist per year. One every other month. Very cheap. In some of the companies I work with, we even have the nutritionist come on site so the person doesn't even miss any lost driving time to and from the office. If you just do that, you can get back that entire missed work week that I showed you 20 slides ago in terms of the average number of missed work days based on those health factors for the year. Very simple and cheap, and it's easy for you to calculate whatever your average cost per day is of an employee, and if you can save 4 and you're paying less than that for the nutrition rider on your health plan, that's an easy win that you can start 1/1 of next year. And there's great data that shows that this is valuable and is helpful. Employees love it. The satisfaction of it is fantastic, particularly if you can bring them on site and they can have a quick visit with them at their lunch break or during their break or something like that, and then they go and make better choices in your worksite cafeteria. One other idea that we do at Duke, which we do in tandem with our physical therapists, is once somebody has a difficult workers' compensation claim, but they have a host of other personal health conditions, either obesity or diabetes or you name it, we help stratify and define when exactly we can end the workers' comp claim. But we don't say, okay, get back to work until you fall and hurt your back again and then we have to operate next year. We say you've got a tremendous number of health risk factors that are increasing your risk of hurting yourself again, whether it's at work or at home. And we're willing to give you free visits with physical therapists, exercise physiologists, and even a 3-month membership at one of the Duke gyms in order for you to kind of develop the idea and the value and maybe a support group that if you take care of yourself, you're going to feel better, you're going to miss less work, you're going to go to the doctor less, and you're probably less likely also to have a repeat workers' compensation injury. And our data on that's been great as well. Other things, and I'll buzz through some of this because I know I'm running short on time, are to get the right people for the job. We talked about that earlier. Understand where your sources of your injuries are. So for example, Duke has a tremendous number of completely sedentary billers and coders for all of the medical operations. I mean, they don't burn 150 calories in a workday. But they're a tremendously high percentage of our workers' comp claims. None of them have anything to do with their job. North Carolina happens to be a state where if you get hurt on Duke property, it's a Duke workers' comp claim. 80% probably of those claims are falling in the parking lot when it's raining or snowy or slick, or slippery stairwells, things that have nothing to do with their actual job. So unless you understand that re-engineering the equipment on an assembly line is important, but that may not be where your injuries are coming from. It may be doing a better job of salting the stupid roads when you have a slick morning in January that saves you 16 really expensive back comp claims or ankle twists or something like that. So in many cases, you've got jobs that are essentially too easy and too sedentary. Anything you can do to stimulate those folks and get them, sometimes we'll have managers do their performance evaluation while on a walk with an employee. so they can both get a little bit of exercise and some privacy, et cetera, for someone who's stuck in their cubicle or on a desk all day long. Other jobs are too hard for the changing demographics that you have because workers are getting older, they're getting heavier, they're getting more and more comorbidities or more health risks. You need to make some of those jobs easier than they were in the 70s and 80s, when it was easier to get young, healthier laborers right out of the military to be able to do these unbelievably difficult jobs that wouldn't pass muster if you started a factory and started that job right now. The Nash lift equations and these other formulas we have wouldn't even allow that to go through, probably, in many cases. Having a robust ADA process and incentivizing your workers, obviously. We know that people are significantly more sensitive to a loss than they are to a gain, at the range of about 2 to 2.5 times. So a $10,000 loss in the stock market gives you the same emotional charge as about a $20,000, $25,000 gain. So it's intuitively makes sense that if we could penalize people for doing the wrong thing, that is going to incent them to make better choices. Obviously, lots of legal issues with that we've run into. You can reward people for good behavior, you can penalize them for bad behavior. The problem is, even if you incentivize somebody $50 or $100 to fill out a health risk assessment, or you penalize them because they're obese, now that the structure has changed and the employee themselves is paying about 40% of the total cost of their health insurance, it becomes a smaller and smaller percentage of what their actual cost is, so they feel less and less incentivized to actually make much of a change. Or if that $100, and they put it into perspective as being a tiny percentage of the 40 grand or 45 grand that they make, then they're less likely to even care or think that that's much of a carrot to begin with. That's become a problem in some of these. So some of the public plans have been the first to make bolder steps in terms of using incentives to change personal behavior. In North Carolina, just this year, if you are a smoker or you're obese above a certain body mass index, then you're no longer eligible to buy the better, cushier plan. You've got to buy the base plan that has higher copays and higher co-deductibles. So in a sense, you're causing obese or diabetic or smoking workers who you statistically know they are going to cost more on your plan. Instead of saying we're going to give you a higher premium, really it's kind of built into the cost structure that they pay, so they're paying a higher percentage of what they consume as they go along. Obviously, legal challenges to this, we'll see how it goes. Interestingly, when we compare, and we're speaking only about American economics here today, but if you compare to what the cost structure is in other countries. So for example, in Japan, there are only about 5% of adults that meet the definition of obese in Japan. But yet, because they have a government health system that's able to put a regulation into place, all companies have to measure the waists of their workers. And if the average male waist isn't less than or equal to 33, and the average female waist isn't less than or equal to 35, then they have to pay a higher tax burden into the national health system, because they recognize that it's a direct cost driver, even though only 5% are obese in Japan. So it's becoming more and more difficult for us to compete in that arena. And I'll buzz through some of these. There are lots of interesting ways that we can try to incentivize workers rather than just a pure dollar and carrot. Actually, what we want to do is incentivize sustainable behavior change. So anybody's willing to forgo cheesecake tonight if you give me $10. What we really care about is, can you do it 6 months from now? Can you do it 6 years from now, when the costs really start to go up? And the research is just very nascent right there in trying to get at what levels of increase down the road is it going to take to sustain your behavior once that wears off and once you don't care so much anymore about that extra $10 a month. The best book that I've read in a very long time is Drive by Daniel Pink, if some of you have read this. A little bit weird, a little bit out there, but I think really gets at the heart of why carrots and sticks worked great for the last couple hundred years, and they still work fantastically in kids and in manual labor jobs and in things that aren't very fun to do. But as our workplace is changing, workers respond dramatically differently to different incentives. And an extrinsic motivator of an extra $10 a month for somebody to do something healthy wears off very quickly. Whereas if you can find ways to build an intrinsic motivation for people to